We're going to be talking today about seeking safety, a therapy for trauma, post-traumatic stress disorder, and substance abuse. I began developing this model in the early 1990s. At that point, there hadn't been a model yet developed that addressed the issue of trauma in the context of substance abuse. We're going to talk about three main topics. First of all, background. What do we know about the connection between trauma, post-traumatic stress, and substance abuse? Rates, gender differences, clinical presentation, and most of all, what is the experience like for these clients? Also, treatment. We're going to talk about seeking safety in particular as a model that attempts to address trauma at the same time as the substance abuse. What's sometimes called integrated treatment, in contrast to older models that were called sequential treatment, the idea that first you treat the drug addiction or substance abuse, and then, and only then, do you go on and treat the trauma or PTSD. And that had been the word in the field for a very long time. And I think at this point, what the field is getting to is the consensus that integrated treatment in general appears to work well for a lot of dual diagnoses, whether depression and substance abuse, borderline personality disorder and substance abuse, and PTSD and substance abuse.
And the problem is that in the past, if we send them to just substance abuse treatment and they stop using substances, their PTSD symptoms go up. And then in the past, for just treatment of PTSD, we tell them they have to be sober for a long period of time before they can receive treatment. And that's particularly difficult for these veterans.
We're also going to look at outcome studies about how clients may change if they're given focused treatment on this connection. First, probably highly familiar to people here, but what I'd like to do is start out right out of the DSM-4 with the definition of PTSD. And many people use the word trauma loosely to mean any difficult event in life. But technically, in the DSM-4, a trauma involves the experience, threat, or witnessing of some sort of physical harm. It might be child abuse, for example, physical abuse or sexual abuse, domestic violence, assault, severe car accident, life-threatening illness, natural disaster like hurricane or tornado, combat experience, and it evoked intense fear, helplessness, or horror. The person was overwhelmed emotionally when the trauma occurred.
When I was selling cocaine, my house got robbed. They kicked in the door, hit me in the head with a sawed-off shotgun in the back of my head. That's all I remember. I woke up in the hospital with a contusion. From there, I got stabbed several times in my back. I just really traumatic. I was devastated.
And remarkably enough, most people who go through traumas do not go on to develop PTSD. The rate is actually 1/3. Still a very important and substantial percentage of people, but nonetheless, 2/3 of people who experience trauma do not go on to develop PTSD. When someone does develop it, it's 3 core sets of symptoms. And it's worth memorizing if you haven't already, because clients often don't know that that's what they're experiencing. And they sometimes feel as though no one quite understands, or they shouldn't reveal how bad they feel inside. So just giving language to their experience. Intrusion, avoidance, and arousal. Intrusion being the person keeps re-experiencing the event over and over in their mind, not wanting to. It keeps coming back in flashbacks and nightmares, intrusive thoughts, and so on.
I knew there was something wrong with me because I get flashbacks. While I'm sleeping, I used to beat up my partner. Like, I'll dream about the things that I've been through, and like I'm back in one of my rapes, and I'll start fighting, and last thing I know, I wake up and my partner will be full of bruises, and I didn't know that I was doing these things.
Avoidance, often called the hallmark of PTSD, because when someone meets the criterion for avoidance, they tend to also meet the other criteria as well. They don't want to talk about the event. They feel very upset by it, but they can't go near it. And arousal, feeling intensely triggered both physically and emotionally when reminded of the event. Hypervigilance, startle reflex, insomnia, intense anger, and so on.
Sometimes I wake up at night streaming. You know, I had some of my roommates to tell me that sometimes I wake up, I'll stream out, you know, and it's from that, the stress, you know, that I went through.
And it endures more than a month. If it's less than a month, it's known as acute stress disorder. But for most people, within 1 month and even up to 3 months, many people will resolve the symptoms. So this is for the people where it endures over a longer period of time. And I'm sure what you've seen in treatment programs are people who have suffered with this disorder for even decades, many, many years, often without it being identified. One of the really unfortunate public health issues at this point is that only 4% of people with PTSD get accurate diagnosis of it, and even fewer get directed treatment toward helping them with it. So still a major issue in the field, both in the mental health and in substance abuse programs, to help these clients identify it and hopefully heal from it.
I had a therapist who I think was just simply not understanding. You know, my first therapist told me that I was suffering from an identity crisis. Despite the fact that I really outlaid, not just the sexual abuses, but several other issues from my childhood.
And it causes some sort of functional problems. The person will say, I don't feel the same as before the event. I feel damaged. I can't focus at work. I can't concentrate. I can't relate to people in the same way. If the trauma in particular was interpersonal in nature, they may feel betrayed. They may feel that they can't trust anymore. They can't reach out or connect with others. And a quote from William Faulkner, the American writer, who said, "The past isn't dead. It isn't even past." And when you think of the nature of trauma for many people, the past lives on until there's some help for these clients to address what happened to them. 2 precepts from H. Wesley Clark, the director of the Center for Substance Abuse Treatment in Washington, D.C. First of all, the idea, no wrong door. It's very important to treat trauma in substance abuse settings, and likewise to attend to and address in some way substance abuse, no matter how the person enters the system. And for a long time, systems have been split. A client would be rejected from substance abuse treatment for being too symptomatic in mental health symptoms, too suicidal, too depressed, too upset, behavior that was out of control. Or the opposite, the client was using, and so the idea in mental health might be, first let them get the addiction dealt with, but we can't take them in while they're still using substances. At this point, a growing recognition in the field is that for many clients, unless they get integrated treatment, no matter how they enter the system, they may not get the help that they need. A second principle, don't ask and they won't tell, that for many clients there's such shame and guilt and hiding of what they lived through. There may have been no one to tell in the past when they went through the traumatic event, or they might have been punished for telling. And so the idea is actively screen for trauma, really help the client identify it, and make assessment systematic and routine for clients so that it's not just when you suspect something may be occurring or may have happened in the past, but making sure to address trauma and substance abuse with all clients, hopefully using validated instruments, of which there really are a number at this point. Even brief self-report screening tools that are done in a systematic way can be very helpful in frontline programs. Also, not a term used in the DSM-IV, but one widely used in the field is the concept of complex PTSD, that particularly for people who underwent trauma at young ages, who went through repetitive trauma, who went through trauma by perpetrators who were in the family, who they were supposed to trust, that there may be much more damage to the personality and to a whole variety of symptoms beyond just the DSM-4 symptoms. Things like self-harm, cutting, burning, self-mutilation, suicidal attempts, and so on. Relationship problems such as distrust, not being able to connect with anyone, or the opposite, connecting in ways that are too close and unhealthy, that don't work for them, such as domestic violence. They keep staying in the relationship even though they keep being hurt, unsafe sex, and so on.
I guess I could start with growing up with my father, who was an alcoholic, and he was abusive to my mother, to the children. And he died when I was 11. And then I got involved with a man when I was 14, and he abused me for 13 years. We managed to have 4 children in that time. And he would wake me up strangling me, he would beat me, he would pretty much do anything he could ever, rape me, he would do anything imaginable.
Boundary problems. The person doesn't know how to set limits with other people in their lives. Sexual problems, paranoia, a sense of distrust toward other people, brief psychotic symptoms, not directly schizophrenia or other psychotic disorders, but just short flashes of either delusions or hallucinations even, where the content often is trauma related, hearing a voice telling them that they're bad, seeing a shadow and being very scared of it, thinking it's something threatening to them.
I started talking to myself, which was something I never done before. And I don't know, I felt like crazy.
Somatic symptoms, the concept that the body remembers, that for some people they express emotional pain in physical ways, and so particularly in children or adolescents, and certainly some adults as well, you see the physical expression in nausea, other kinds of physical problems. Dissociation, the tendency of the client to unwittingly often remove themselves psychologically from the present environment. Sometimes they're triggered by something connected to the trauma. They'll describe it as spacing out. Their eyes may look glazed over. They may look like they're no longer with you. But it's a very common symptom for people who've experienced severe trauma. And one of the things we'll be talking about is how to bring the client back, how to help the client reconnect with the present. Reenactments, the tendency to repeat in behavior what they haven't yet processed or fully dealt with emotionally. So cycles of bad relationships, cycles of continually getting into struggles or fights with people, inability to get along, inability to sustain gains, and so on. And finally, loss of sense of self, sometimes feeling fragmented, feeling empty, feeling split in some way. And a quote from David Kaloff, who said, they constantly tell their stories, sometimes with words. The idea that for a lot of these clients, they will repeat in behavior a lot of their traumatic experience until it's addressed, named, and worked with. Also, community-based epidemiology studies have looked at the co-occurrence between PTSD and substance use disorder. A major study was Kessler in 1995, who found very high rates of co-occurrence. Among men with PTSD, 52% develop alcohol use disorder in their lifetime, and 35% develop drug use disorder. Among women, the rates are 28% and 27% respectively. So very high association between the two. And in treatment settings, you actually see much higher rates. For example, in substance abuse treatment programs, 30 to 59% of women have current PTSD, and 55 to 99% of them have experienced at least one and often more lifetime traumas.
I just think it's very important to realize the connection between people that have experienced trauma and are diagnosed with PTSD, and how addiction plays a role with that. Because for years I didn't know about that connection. And now that it makes really a lot of sense to me, knowing that with the flashbacks and nightmares, the hypervigilance I have, the startle response, that is PTSD, and then along with my history of addiction, it helps me take it off more of a moral stance, so that I understand that I'm not a terrible person, which is what I thought for years. I have a terrible disease. I am an alcoholic and an addict. I have a history of trauma, PTSD, and a history of depression. And so I'm beginning to understand now why I have such a long history of addiction, and how I've used addiction to treat the trauma.
And a very clear and consistent finding that those who experience both disorders tend to have worse outcomes than those with either disorder alone. In a series of studies by Dr. Paige Wimett, those with PTSD and substance abuse improved less, had worse coping, more distress, and more positive use of substances than those with substance abuse alone. And often a feeling of being crazy, lazy, or bad, an internalized sense that somehow they have failed, that something is terribly wrong with them, that people won't understand, that people will think that they're sick or damaged in some way, and often hiding some of those internal experiences.
One of the really positive things I think that comes from the treatment is it gives clients a chance to make the connection between PTSD and their substance abuse, and more importantly, I think, to identify that some of the things that they experience are PTSD, to have a name for what their experiences are. I've had women say that, it's almost so this is why I feel the way I feel, or so this is why this happens to me, or so this is why I think this way or act this way, because they've had this perception that there's just something wrong with them as a person, that they have some sort of horrible defect, or that that they're just plain crazy for some of the things that some of the experiences that they have. So to have a name to attach to it is often a very positive experience.
Unfortunately, sometimes in families and even in treatment programs, they may get messages that reinforce that. Just get over it, move along already. That event happened 20, 30 years ago. You should just focus on the sobriety and so on. You're defocusing if you attend to the trauma. And a little more about PTSD and substance abuse, and then we'll go on and talk about treatment. For most clients, for 2/3, the PTSD occurs first and then the substance abuse develops, fitting what we often think of as a self-medication that the clients may be using as a way to escape emotional pain, as a way to numb out.
I think with trauma, you look for escapes. You look for, because if you're constantly thinking about or in the middle of what it is that you've experienced that's really horrific, then you would have no peace at all. And so one of the ways of trying to distract from remembering different things is to do things that I like, or things that will numb you to the effects of how the trauma has manifested itself in your life.
It certainly goes in the other direction as well, that clients who abuse substances are at higher risk for traumatic events and thus the development of PTSD. The lifestyle of addiction, spending time with dangerous people, dangerous situations, crime associated with drug use and so on may lead people to more traumatic events. And certainly for some people, they grew up with both, sometimes in the family very early on. One of the major predictors of who develops both of these disorders is family history. And unfortunately, there's the repeated cycle over generations of these illnesses, particularly when people go untreated.
I grew up in an alcoholic home, and my dad was an alcoholic, and he was, my house was pretty crazy. He also, I'm convinced, suffered from PTSD from the war. He was in World War II, and there was a lot of tension always in the house, and it would occasionally explode into craziness. You know, I can remember many times as a little kid being, you know, frozen in fear. I thought it was normal. You know, I ended up being a very, very withdrawn kid. You know, very shy, and you know, basically, I wasn't very good socially at all. You know, I had no social skills whatsoever until they poured a drink into me.
Two key themes in treatment: control and secrecy. When you think of the very nature of PTSD, no one ever asks for a traumatic event to occur. It's always unwanted and uncontrollable. When you think of substance abuse, by definition, it means the person has lost control over their use. And so what you often see in these clients are struggles around control, difficulty taking control of their lives. They'll often say, life just happens to me. I don't plan, I don't direct things, I don't try to actively cope. Or the opposite, sometimes over-controlling, getting into struggles, not being able to work with others and adapt to rules. And so in treatment, one key goal is empowerment, helping the client take control in healthy ways. Another theme is secrecy. Really, more than a lot of other Axis 1 disorders, both PTSD and substance abuse are beset by hiding, lying, minimization, guilt, and shame. No one they could tell about the traumatic event, wanting to hide the substance use, certainly even from themselves. And so there too, in treatment, one of the goals is to help the client learn how and when to open up and to be honest. When is it safe to do that? But the idea that with someone at some point they need to be able to be honest about both. There's no particular drug of choice for the dual diagnosis, but the use of hard drugs is common, meaning cocaine and opiates. Also, misuse of prescription medications is very common. PTSD is classified as an anxiety disorder in the DSM-IV, and so what you often see is an attempt to reduce anxiety by use of substances.
I drank to relieve the pain. You know, I was a very confused kid. You know, I had all these feelings, low self-esteem, you know, fear, anxiety, and you know, the alcohol lessened the anxiety. You know, I was always anxious. I was never able to relax.
PTSD does not go away with abstinence and may get worse in many cases. This is different from some other dual diagnoses. For example, major depression, generalized anxiety, typically tend to get better the longer the client maintains abstinence from substances. With PTSD, one often has to help the client prepare that they may worsen in trauma-related symptoms. They may get flooded with the overwhelming memory and emotion that they've been pushing away with the substance abuse. Also, people can recover from PTSD. One of clients' most urgent and deep questions is, will I ever get better? And one thing we know about PTSD is that in some cases, full recovery is possible. Typically, if they suffered one event in adulthood, it's more likely that they'll have full recovery, in contrast to people with what we termed earlier complex PTSD, repetitive events, childhood-based, often within the family. But nonetheless, for all clients with PTSD, whatever type of origin it was, clients can recover to the point of no longer meeting criteria for the diagnosis. They can live a functional life, and basically they can move on and move forward. And it's up to them ultimately to determine how full that recovery is. Many people will say they never feel that their lives will ever be the same given what happened to them, but nonetheless, they can go on.
I feel very grateful that I've been able to identify my history. Because I could never understand what was wrong with me. And now that I've been able to identify it, I can move on. I don't feel like my feet are stuck anymore. And I don't look at it as painful. I mean, I look at the pain as being difficult, but I also look at it as being a way that I can move on. I feel very optimistic. and I'm a survivor. And I can say I'm going forward.
Why are clients using? One hears a lot of different meanings for drug use in the context of PTSD. I use drugs to access feelings or memories. I feel numb, I feel detached, I feel dead. And using just helps me to feel something, feel alive. Drugs to shut off feelings or memories. I'm overwhelmed, I can't cope, I can't get through the day. And so using just helps me to relax, to calm down.
I liked the marijuana because it was calming to me. I could still function, and I smoked, that's what I did for a long time. And then I went to the alcohol because it just went away. It was different. All the pain went away. I didn't care. He'd beat me, I'd get drunk and wake up in the morning and forget about it. It didn't matter. I felt comfortable in my own skin, I guess. I liked it. I liked being able to pass out. I liked being able to go to sleep and just forget it all.
I've learned through years of counseling and searching for an answer that I drank because two reasons. I needed to feel or I needed to not feel.
Drugs is revenge against an abuser. This was my only way to control my body when something was happening to me. Drugs is slow suicide. I want to die anyway. And so whether it's drug use or something else, I don't really care. And in fact, among people with PTSD, not even taking into account the substance abuse, 19% will attempt suicide at some point in their lifetime. And so very important to attend to suicidality, to those wishes to escape through death. Drugs is learned behavior. This is how I learned to cope growing up. This is what we did in my family. We drank, we used a substance. And very important to give clients a lot of reassurance about PTSD. It's okay to be in pain. Often just the permission to know that they're upset is okay, that they can experience that. People do recover. That in fact, some people will have complete remission, complete absence of symptoms, no longer meet criteria for the disorder. You're not crazy, it's a normal reaction to abnormal events. That was a definition used in the original diagnosis of PTSD in 1980. Eventually, epidemiology data showed that in fact, trauma is in fact very common. In the US population, about 60% of men and about 50% of women experience at least one trauma in their lifetime. And so it's really not an abnormal event. Nonetheless, it's a great phrase to use with clients, and it can help them feel validated, feel normalized. And finally, it's not your fault. And a lot of these messages will take a lot of repetition. It's certainly easy to say it's not one's fault, but the client may take years to really get to that concept at a deep level.
It was nice to know that there was a reason for this, and that it could be corrected, rather than being sentenced to this for the rest of my life. These feelings. It was nice to know that it wasn't me. It wasn't my fault.
Talking now about treatment, a quote from Rainer Maria Rilke, the 20th century German poet, who said, "For ultimately, and precisely in the deepest and most important matters, we're unspeakably alone, and many things must happen. Many things must go right. A whole constellation of events must occur for one human being to successfully advise or help another." And I think it speaks both to how difficult and challenging this work can be, but also how gratifying it is when you can really reach someone. A concept that's become very important in the field over the past several years is trauma-informed treatment. The idea that it's important to train all staff in trauma and PTSD, clinicians, administrators, secretaries, security staff, that at every level of a program, everyone needs to understand how trauma may impact the client's behavior and take it into account in responding to that client. Trauma essentially becomes a lens, both for staff and for clients, to understand why sometimes they get too angry, why they get into fights with people, why they have trouble following rules, and some of the other often perceived difficult behavior that clients can present in treatment programs. Routine assessment for trauma and PTSD. The idea that at this point, in many programs, it's not routine, or people use unvalidated measures. So the idea of moving towards systematic and solid assessments of all clients. And it's helpful to distinguish trauma-informed services from trauma-specific services. Trauma-informed services means basic trauma education, that all staff need to become trauma aware. Some staff may become providers of trauma-specific services, may actually do counseling or therapy that focuses directly on the trauma and PTSD. And those staff, fewer in number, will become trauma competent. They're the ones who can directly help the client heal from the trauma.
We took this work and implemented it really clinic-wide, and we took a technology transfer perspective around really looking at systematic change, around not just doing a few groups, but really fundamentally thinking about trauma-informed treatment and how to implement this culturally within the program. So that was the first piece. We all are familiar with groups that maybe one or two people may run, and trauma-informed treatment is no exception, where a few clinicians may conduct the groups. What we found, it was really essential to include all levels of the clinic, to include senior staff, frontline staff, administrative staff, to really have inclusion so that not only we had buy-in from all levels of staff, but that we were mindful of our environment being trauma-informed. That was really the fundamental goal for us.
So how is PTSD typically addressed? Unfortunately, in a lot of programs, not at all. Both mental health and substance abuse settings, one often sees no direct attention to trauma or PTSD. If it is addressed, there are basically two ways to go about it. And it's very important to think out with each client which way you're going to go and having a clear rationale for that. The most underestimated method is focusing on the present, that you can actually treat PTSD just staying in the present, focusing on current symptoms, psychoeducation, teaching the client what PTSD is, the rates, the gender differences, how it presents in their behavior, and so on. And most of all, teaching them coping skills. What can they do when they're having a flashback, a nightmare, when they're overwhelmed with emotion? Seeking safety is one model that's present focus that we'll be talking about in a few moments. Focusing on the past is state-of-the-art treatment for PTSD and has been extensively studied and found to be effective, going by a lot of different names. Exposure therapy is a very well-known model. Essentially having the client retell the trauma narrative, the trauma story, and connecting to the emotion of it. Preferably talking in the present tense. I walked into the room, he came at me suddenly. I remember the light was coming in the window at an angle. As they're telling this story, the emotion goes way up. And what you're hoping the client will experience is that they can get to the emotion, but then the emotion will also come back down. And by the end of every single exposure therapy session, you help the client bring the emotions back down. And they learn that they can tolerate the intense feelings that go with the trauma memories. Rage, sadness, panic, anxiety, crying, and so on. And with each retelling of the story, the intensity of the emotion is a little bit less until finally they can tell the story with it no longer having the emotional hold over them that it used to. It's very comparable to how people in general deal with loss. We have rituals around mourning, funerals, social support to help the person go through the memories of the deceased, and so on. And the process is very similar, going through the feelings, feeling them directly, and eventually the feelings lessen. Eye movement desensitization and reprocessing, also a very popular model for discussing and describing trauma memories, also found to be effective in scientific studies. Telling your story, mourning, and trauma processing are other terms that people use for that same type of healing. One issue with methods that focus on the past is that for clients with substance abuse, they may not be ready to do that kind of work. One of the biggest dangers is that if a client is already showing that they're impulsive, that they can't control their behavior, that they keep getting into dangerous situations, if you have them then delve into the past, what can essentially happen is they can end up worse, using substances more dangerous behaviors of all kinds, such as self-mutilation, unsafe behavior, and so on.
If I talk about it, it gets me upset. But as soon as I stop talking about it, I try to forget it. So I haven't really dealt with it yet, not totally, because it's just too much, just way too much. It's too damaging, I think, way too damaging. Because you're left with all these emotions and you don't know what to do with them. You know, and you can't have your therapist with you 24/7. It just doesn't work that way.
And so the idea now is you may or may not be doing it certainly early in treatment, and you may not at any point do it. Studies that have directly compared methods that focus on the present versus methods that focus on the past, just in terms of PTSD, not addressing substance abuse. At this point, there are no studies on that topic. But in studies that directly compare present-focused methods with past-focused methods, basically you see similar results. And so really helping understand which way the client wants to go. In the early 1990s, I received a grant from the National Institute on Drug Abuse to develop a model of treatment for PTSD and substance use disorder. Thus far, there have been a variety of studies of seeking safety. Some examples of some of the pilot studies, one on women outpatients, women in prison, men outpatients, men and women veterans, and 2 controlled trials, one on low-income urban women and one on adolescent girls. And the website www.seekingsafety.org always has a paragraph on each study and also the full article that you can download. I was very inspired by Judith Herman's book, Trauma and Recovery, published in 1992, in which she reviewed over 100 years of clinical description of how people recover from traumatic events. And people have used different terms for it, but essentially, she identified 3 key stages. First, the idea of safety, that the client needs to get out of dangerous relationships, stop misusing or abusing substances if they're doing that, learn coping skills, learn how to function, learn to decrease some of the key symptoms of PTSD. Basically, getting a foundation from which they may go on and do the phase of mourning. In mourning, the client directly tells the trauma story with all the emotion connected to that and tries to create some sort of meaning from it. Finally, having done that, they can reconnect in healthy ways, a good work life, good relationships, and so on. And I decided to focus just on that first stage of safety. How do you help a client just do that foundation work? In seeking safety, it focuses only on that first phase of treatment, because the idea is that when someone has both substance abuse and trauma-related symptoms or PTSD, they need a lot of help just learning how to get through the day, learning how to be able to succeed in life in terms of functioning, in terms of working, in terms of relationships, and so on. And throughout Seeking Safety, from the very title and throughout every topic, there's a focus on helping the client distinguish safety versus danger. They often don't know when their own thinking is unsafe, their own behavior, or when people might be dangerous for them. And so there's a list, for example, of over 80 safe coping skills. There's a safety contract, a safety plan. At the beginning of every session, they check in about their safe and unsafe behaviors of that week, with unsafe behaviors being whatever they or the clinician decides is unsafe. It might be internet addiction, gambling addiction, hanging out with people who are dangerous to them, cutting, burning, binging, purging, any behavior that's currently causing problems in their life. The format of the treatment is 25 topics, evenly divided between cognitive, behavioral, and interpersonal themes. And the idea was to be highly flexible. In many frontline programs, there's a shortage of resources. Typically, clients in substance abuse treatment, for example, will never get individual therapy. In many programs, the stays are quite short. And so the idea was to design a model that could be used no matter how short or how long the program was.
Some clients I meet with once a week. There have been clients that have been in crisis that I suggested that we meet twice a week for a short time to kind of get them through the crisis, and that's been very helpful. I also have no problem with a particular session, spending a couple of weeks on it. I tend to do that quite a bit of the time.
So it can be conducted in few sessions or many sessions. In the setting where I work, for example, clients sometimes come in for a 3-day detoxification from substances. In that time period, you can still teach them about PTSD. You can still teach them 1 or 2 coping skills that may help them when they walk out the door. Or if you have the luxury of a 6-month residential program or some extended stay, what you can do is take each topic and do it over multiple sessions. Every topic has multiple handouts, and the idea is to really use the material in ways that help the client deepen the work. It can be used for group or individual treatment, and the format is identical. The topics and handouts can be done in any order. You may decide that a client has a particular issue and you would like to go to the 3rd topic in the manual. Or the client may decide on seeing the list of topics that there's something that they would like to address. Similarly, in every session, when you give the handouts, the idea is to let them scan through them and then go where they want to go. Ask them a question like, what strikes you? What do you notice? What would you like to focus on? And just let them move amongst the handouts. It can be run in open groups or closed groups, depending on the setting. In many settings, clients come and go frequently, and so closed groups really aren't an option. And the idea is clients can join at any point along the way. Typically, it helps to have the client do at least the topic PTSD before they join the group, just so that they'll have a language to share in common with other clients who know what that is. But basically, clients are ready to go once they have that basic understanding. It can be used with women, men, or mixed gender. In general, single gender is preferred if possible. Clients tend to feel safer, and there's a different dynamic if it's all women or all men. But basically, it can be done in whatever form you're normally running other groups. Outpatient, inpatient, residential, and can be conducted by counselors. Counselors who are familiar, for example, with relapse prevention tend to feel comfortable with it because the idea is it's coping skills oriented. Because it doesn't ask the client to go back into the past, and in fact specifically tells the client, we're not going to be doing that at this point. It doesn't tend to evoke intense emotion or unstable behaviors.
Some of the other things that were really important was the work is skills-based. And I can't emphasize that enough, because a number of the clients reported that talking about trauma would have been something they would have been unwilling to do and had been part of the resistance for them to deal with these issues in the past. So the fact that it was skills-based and also, very importantly, that it was present-focused was really fundamental to them.
The session length and pacing can adapt to the setting. Some people do it once a week for an hour as a group, for example, or twice a week for 90 minutes. Whatever the basic intensity is of the other kinds of groups that are done in the setting tends to work. The treatment is structured, which is by design. The nature of PTSD and substance abuse tends to be impulsive, overwhelmed, not planning well, not really coping, not sort of knowing how to use time and so on. And so the idea is that in the very format of the session, to help the client learn what it is to pace, to share time, if it's a group, for example, and basically to understand that there's a certain consistency around how the structure of this session goes.
A number of the clients reported that having the familiarity of the group context, coming in each week and having some sense of structure and stability was really important for them in feeling comfortable. Knowing and being able to anticipate the environment was really important for them. So we heard that a number of times.
The format of the session starts with a check-in. Since the last session, how are you feeling? And feeling does not have to be an emotion word. They don't have to say anxious, depressed, angry. It's basically an update. How are you doing? What's new in your life now? What do you want to let us know? What safe coping have you done since the last session? The idea is to always reinforce gains. These clients often have so much demoralization and low self-esteem that they don't tend to notice what they do well. Any substance use or other unsafe behavior, however you and they might define unsafe behavior. Binging, purging, self-mutilation, suicidal attempts, gambling, hanging out with dangerous people, and so on. Did you complete your commitment? The commitment is essentially like homework in cognitive behavioral therapy, but the term commitment is used because it's almost a higher order word. They're committing to their recovery. They're making a promise to do something, no matter how small, to improve their lives between now and the next session. Case management update. In an initial study on this population, I found very low rates of clients utilizing treatments. And you tend to find sometimes that they stay isolated, they don't reach out for help. And so the idea is from the very start of treatment to do a systematic assessment of a whole variety of case management areas, and then throughout the treatment to try and link them up with services that they might need, whether it's parenting skills, medication, inpatient stay, 12-step groups, job counseling. Then a quotation, which is designed to help them connect emotionally with the topic. Just a very brief 1 to 2 minute intervention to inspire them to work on the topic that's going to be addressed. For example, the session PTSD has a quote from Jesse Jackson. He said, "You're not responsible for being down, but you are responsible for getting up." And a client reads the quote out loud, and then we just discuss what's the main point and link it back to the topic. It's not your fault that trauma happened to you, that you lived through these horrific events, but there is a lot you can do now to get better.
With the quotations, they were actually kind of funny. They would take them out and tell them to their peers, you know, the quotations. I would come in the morning and find them up on the chalkboard, you know, as like inspirational sayings for the day, things like that. So they really resonated with the quotes.
The topics can be done in any order, but typically starts with introduction and case management, helping the client learn that the treatment will not focus on having them tell details of their traumatic event, nor hear it from other people. And for some clients, that's actually a relief because they may feel afraid to hear some of that material at this point. Case management is a systematic assessment of 16 different areas of possible needs, including parenting skills, medication, 12-step groups, leisure time skills, and so on. Safety. How to help the client feel safe and imagine what safety would look like in their lives. In this topic, they're given a list of over 80 safe coping skills, and the idea is throughout the treatment to come back to the skills. If they say, I don't know how to cope with this event that's going on right now, one can always draw them back to the list and say, any ideas there, anything that might work for you? And the idea is really to give them a very large menu of options, and there's nothing particular that they have to use or have to learn. The idea is to empower them to make a choice. And if something doesn't work for them, just let it go. What else might work for you here?
I found that if I didn't have coping skills, I would relapse. I have a long history of relapse. Without the coping skills, I didn't really learn how to sit with myself and deal with the feelings that came up. Flashbacks, nightmares, you know, symptoms associated with the PTSD.
It's so easy to feel, with PTSD, I mean, you feel powerless. You know, the feeling of powerlessness is throughout, and then you take that and you put it into a prison setting, and you know, it's easy to feel even more powerless. So I think the safe coping skills gave them a way to feel in control of how they felt and how they acted, and more empowered in the setting that they were in an internal way, because there's so few kind of external ways that they can be in control and be empowered.
In the topic safety, they also learn about the 3 stages of treatment, that the first stage is safety, learning how to establish functioning and basically reduce symptoms. The next topic is PTSD, taking back your power, where they learn the symptoms of both simple and complex PTSD. They also learn that taking back your power means being compassionate about your experience, understanding that you didn't control these events, but that these events have very much affected how you are now. Substance abuse, picking a way to get and stay abstinent from substances. In most programs that will be an abstinence focus, but in some programs it may be harm reduction, being willing to work with the client to reduce use in whatever ways they're willing to reduce it now. If they were using 2 substances such as heroin and alcohol and they're willing to give up the heroin, that's a great step forward. If they were using every day and they're willing to go down to every other day, that's a great step forward too. But again, depending on the program and being very respectful of program policies, one helps the client identify how they're going to get abstinent. If they do pick a harm reduction approach, it's very important that there be a contract around it, that it's not licensed to just use, but that there are specific limits around it. I will use no more than 1 drink a day, measured with a shot glass, or so on. In the topic substance abuse, they also learn about the value of 12-step groups. Many of them already attend those groups. But they also learn the idea that 12-step groups were not designed to address trauma or PTSD. And so to really make use of those groups for what they can offer, but to also know that they may need other places to address trauma and PTSD.
Many of these clients have such incredible low sense of self when they come to the group because they have failed at past attempts of remaining sober. And the way that the model works is wonderful for them because they learn that, okay, if they have a slip, they can figure out what they need to do in order to stay sober in the future, and that it is not the end of the world. And they can also receive support from the group instead of criticism for having slipped. And that works very well. So I think where it really helps them is that the material helps them to build self-confidence in their ability to manage their symptoms of both substance dependence and PTSD.
Asking for help, how to reach out when they feel that they're overwhelmed or can't cope, not to feel isolated and alone. Detaching from emotional pain, also called grounding, one of the key skills in the treatment. Basically a way to help the client reconnect with the present. And for many clients, what you'll find is that they go from 0 to 100 in a heartbeat. They feel escalated, they feel intensely angry, they feel intensely triggered, they feel an intense drug craving. And so they need some method to be able to reduce those intense feelings and to do it no matter where they are. First, they learn that the goal is to use all their senses to focus outward on the world rather than inward toward the self. It's the opposite of what we normally do in therapy. Typically in therapy, you have the client get in touch with and express their feelings. But the idea here is that when the client is overly intensely negative in their emotion, they need to bring it down, particularly in early phase treatments such as this, where your goal is to help them cope. So you typically will have them rate their feelings, and this may happen during the course of a session. You see that the client is reacting very intensely. You might say, right now, 0 to 10, how upset do you feel? 0 being not at all, 10 being extremely. The client may say, I'm at an 8. I am really angry. I feel ready to punch that wall. And so what you might say to the client is, could we do some grounding now? Could we try and help reduce those feelings? And once you teach them the skill, they can typically use it no matter where they are. They might be riding the bus, they may be sitting in a meeting. Wherever they are, they can actually learn to do it silently to themselves. Grounding has 3 basic methods: physical, mental, and soothing. In physical grounding, you have them touch and describe objects. For example, pick up this pen. Is it heavy or light? Is it warm or cold? Is it rough or smooth? What is it made of? And so on. You might have them look around the room and describe colors. Name all the colors you can see: white, green, red, pink, blue, purple, and so on. And when they start to no longer be able to name some, you just switch to a new question. You just want to keep them going on this present-focused sensory experience. Describe objects you see in the room: tables, chairs, computer, and so forth. Mental grounding. Play a categories game. Name all the TV shows you can name, or name all the sports teams. Name all the animals you can name foods, just anything that will get them focused in their mind. Soothing grounding, describe a safe place. Sometimes that'll be worked out ahead of time, such as they love the image of a beach or a park. You can also say to the client that right now in this room, we're safe. Do you want to describe the room? Think of your favorite season of the year. What season is it?
Fall.
Now think of your favorite time of day. What time of day is it?
Early morning.
Think of a favorite person. It may be someone you know, or it could be a famous person. Picture that person. Taking good care of yourself, how to take care of their body and their environment. And with each of these topics, the idea is to help them understand also the bigger picture. Why might it be hard to take care of themselves if they experience trauma and substance abuse? Maybe there were no models in the family of how to take care of themselves. Maybe due to the addiction, they stopped taking care of their body. So for example, in the topic, taking good care of yourself, the clients will go through a set of simple yes/no questions. Do you have annual medical checkups? Do you take all medications as prescribed? Do you always drive substance-free? Do you have at least an hour of free time a day? Do you take vitamins daily? Do you avoid walking or jogging alone at night? Do you have at least one social contact every week? Do you spend within your financial means? And so on. And typically, if we're doing it in a group, clients may report how many yeses did they have, how many no's did they have, and then they'll pick one to make an action plan about. What's one thing you can do this week to improve your self-care? Maybe just buying a bottle of vitamins and starting to take them, making that dentist appointment if you haven't been to the dentist in years. Setting boundaries in relationships, how to say yes to healthy relationships and no to unhealthy ones. And so the idea is help them learn how to find safe people. Community resources. A very lengthy list of nonprofit toll-free numbers that the client can call for information about key topics related to these two disorders. Mental health, substance abuse, parenting skills, physical health problems, HIV risk, domestic violence, and so on. And the idea there too is to empower them to take a consumer approach that they can seek out services and seek out information that may help their care. Recovery thinking, essentially cognitive therapy, but applied to this dual diagnosis. What are thoughts associated with PTSD and with substance abuse? And in contrast, what are recovery thoughts? What would be a different way of thinking about things? And helping them learn to train their mind to go to a reframing, to rethink situations in a healthier way. Compassion, how to take a view of understanding their current situation in light of what they've lived through. And too often with these clients, they have not been given that perspective. Helping them learn that substance use, of course, is always a choice and that they are the ones picking up the substance. But nonetheless, even though there are no excuses, there are explanations for it. There are reasons why substance abuse is so common in people who have been traumatized.
What I took out of the treatment, you know, compassion, kindness. Those things were very short in my life for a long time. You know, you have a certain amount of self-loathing, shame, and I didn't know how to get rid of it. You know, kindness and compassion and understanding. Those things are pretty powerful. You know, it helped me change.
Creating meaning. It's been found that people who can create positive meanings may have quicker recovery from PTSD, and helping them learn to come up with themes or beliefs, ideas that may help inspire them to keep moving forward in their recovery. Commitment, how to make and keep a promise. And often these clients will say that people have broken promises to them throughout their lives and they never learned how do you follow through on things? How do you do things even though you don't feel like it? And so there's some specific behavioral skills and also attention to the emotions that they may need to attend to in order to just follow through. And if you remember, at the end of every session, they make a commitment of one thing they'll do before the next session. Whatever it might be, however small it might be, the idea is to continually reinforce moving forward in their lives.
When they do the homework, they really seem to get a lot out of it. They realize that their treatment is moving along faster than if they don't do the homework, but that's certainly one of the things that I hear from them is, you know, oh, I don't have time to do the homework, and I don't have time to practice the skills outside of the session. That's certainly been a focus of my work with all the clients, is to encourage them to practice the skills outside the session, not just in the hour that we meet during the week, that it's very important that they practice that.
Honesty. One of the topics that clients say may be one of the most important topics to them. How and when to open up, both around the substance abuse and the trauma. Coping with triggers, standard relapse prevention, basically in the words of AA, change people, places, and things. What to do when they're triggered, how to avoid triggers, and so on. Healing from anger, the idea that anger often is inevitable for many of these clients. Anyone would feel angry if they lived through what these clients have lived through. But that anger can be used either constructively or destructively. Destructive anger is acting out against self or others, self-harm, self-mutilation, and so on. Constructive anger is hearing the anger as a signal that they can listen to and respond to. If they keep getting angry at someone, maybe that's not a relationship that they should be in at this point. Or maybe they need to talk to the person and negotiate something in that relationship. So anger itself isn't a problem, it's more how do they deal with it and how can they use it constructively. Discovery, a concept in cognitive therapy of identifying a belief that they can go out into the world and test. And for many of these clients, their thinking has become rigid. They think in old patterns. It's hard to get unstuck. And so the idea here is identify a belief that is testable. For example, if I went to AA, I would hate it. If I apply for a job, I won't get it, and so on. And then have them go out, find out what happens, and come back and report on it. Now, sometimes they'll find out bad news. It didn't go well, and they were right in their prediction. But the idea is that all knowledge is power, and that they can use that information. If they didn't get the job, they can do job counseling or get some assistance in how to apply for a job, and so forth. Self-nurturing. How to have pleasure in healthy ways. Substances often were a way to feel good that ultimately ended up being very destructive in their lives. Pain and pleasure may have become very distorted concepts for these clients. Particularly if sexual abuse was there early on, they may have confusion or fear about pleasure in their lives. Some of them will say they haven't experienced pleasure in years. And the idea is help them identify ways to feel pleasure in healthy ways. It might be taking a walk, taking a bath, playing with a pet, and so on. Getting others to support your recovery. Basically trying to involve safe family members or friends who can come in and get some education about PTSD and substance abuse. One thing many clients say is that it's very painful to them that no one seems to understand about the trauma, that family members may view it as an excuse. That's just an excuse for not working on addiction, and so on. And the idea here is to bring in the family member, give that family member some resources as well, whether Al-Anon, referral to couples counseling or family therapy, whatever might work for that particular client and their family. Many clients have no one to bring in, and then we focus basically on how can you get people in your life who will be healthy for you. Respecting your time, how to schedule your day so that there's some amount of time that's productive, that's planned. Both with substance abuse and mental illness, one thing we know is that the client who has no structure, no activities during the day, tends to get worse and more symptomatic. So giving them literally a schedule blank and then having them fill it out, looking at how they've spent time in the past week and how they might spend time in the week up ahead, future focused. And the idea is that time is the ultimate resource. They may have lost time in the past due to these disorders, but there's a lot they can do now to make their future better. And looking at issues like, do they spend a balance between time alone and time with other people, recovery activities and other activities, structured time and leisure time, and so on. Healthy relationships. What are the signs and beliefs that go along with healthy relationships? And for many clients, just discussing these ideas out loud can help them learn to identify some long-held beliefs they may have about what they tolerate in relationships that maybe they shouldn't have to tolerate, or how they maybe could get into relationships that might be healthier for them.
And when it would get physical and if you hit me or something, I didn't, after it happened like a few times, and almost to me because I was still drinking, that it just seemed like part of the life, like that's just the way it is. It's almost like I knew better, but I felt like I didn't know any better. It was just what was supposed to happen. And it didn't really bother me. It was just like putting on my shoes in the morning. It was just what I did.
Integrating the split self, really more than most other Axis 1 disorders, there's the concept of splitting in both PTSD and substance abuse. In PTSD, clients will often say there's some side of the self that they're trying to push away. The young side, the angry side, the weak side, the vulnerable side. When I was weak, that's when I would get hurt, so I've learned never to show weakness. In very severe cases, you have what's called dissociative identity disorder, where the client may have literally alters or different personalities within the self who may or may not even know each other. Different genders, different ages, different personalities. Those clients will need very expert, long-term, and focused help with that. But even in clients who don't have that full-blown dissociative identity disorder, you often see these splits within people with PTSD. In substance abuse, what's sometimes called the Jekyll and Hyde personality. I'm with the program, I want to get clean and sober, and then suddenly they flip into a different state of mind. I don't know, I was walking past the bar and I just found myself in there getting a drink. And the nature of these splits, until they're recognized and integrated, often is unconscious, and they may flip from one state to the other without actually recognizing that it's happening. And a lot of dangerous behavior tends to occur when these flips of state of mind happen. So helping the client learn that ultimately integration is the goal, owning all sides of the self. Red and green flags, what are the signs that they're getting worse or spiraling downward, and the signs of getting better and spiraling upward? And clients identify here from a checklist a variety of behaviors, attitudes, and so on that may sort of help to signal them for when they're going downhill. When I get cynical, when I get too angry, when I stop attending AA meetings, when I stop showing up for treatment, when I isolate, and so forth. And in this topic, they're also taught to create a safety plan. What will they do at mild, moderate, and severe levels of danger? And hopefully sharing this plan with other treaters and with family members so everyone can help the client identify if they're in a downward spiral and hopefully shore them up, get them the support they need, and move back to a better place. The Life Choices game, a review topic, basically designed to be random like life. They pick a slip of paper from a little box or a hat, and it has on it a very difficult life event. And the idea is to pull out the slip of paper, read the situation out loud, and here's their test. How would they cope with this event without any substance use or any other unsafe behavior? The slip of paper might say, you just lost your job. You found out your partner is cheating on you. You found out that your daughter has been abused, and so on. And the client has learned, hopefully by this point, that no matter what happens in life, there's a way to cope safely without substances or any other unsafe behavior. Finally, termination, saying goodbye and planning aftercare. And typically that process starts occurring way earlier in the treatment. It can take a long time to do that work, but nonetheless, ultimately terminating eventually with the treatment. And throughout the treatment, strong attention to language, words like safety, respect, honor, and healing. Simple language, trying not to use jargon or scientific sounding terms, trying to connect with them emotionally at the level of language. Finally, a checkout. Name one thing you got out of today's session and any problems with the session. That comes from educational research where it was found that students in school actually learn more if the student identifies one thing they learned in that classroom session. And the idea here is this also helps the clinician get some feedback. What made a difference to the client? And it may or may not relate to the topic that was covered. Any problems with the session is to help the client learn to express if they're having a negative reaction. The goal is to kind of to try to retain the client in treatment. And some of these clients will be over solicitous of authority figures. And so the idea is always ask them what they don't like. It doesn't have to be addressed right now. One can just hear the feedback, maybe make a plan to discuss it after the session, or just say, thank you for being honest about that. But basically just listening to it. What's your new commitment? Picking something they can do between now and the next session to move forward in their lives. And they're committing to themselves, to you as the clinician, and to the group if it's a group treatment. The commitment does not have to be written. Many of these clients do not like written assignments. They didn't do well in school. The idea is really just to pick something, whether it's making an appointment with a healthcare provider, asking a boyfriend not to offer them substances, whatever it might be. The treatment philosophy overall goes back to a set of core principles. Safety as the priority, that is the thing to focus the client on. Integrated treatment of both PTSD and substance abuse. The idea is that PTSD and substance abuse can be treated together from the very start of treatment. The client doesn't need to be stabilized before working on PTSD if the focus is present-focused, coping skills, psychoeducation, and so on.
The integrated approach was really fundamental for them in being able to connect the substance use around the symptoms of PTSD, such as an intrusive thought or being triggered by a scent, a place, an idea, dreams, sleep disturbances, those kinds of things. In many cases led those clients to use substances. So for them, when they made that integration, not only within the group, but within themselves, when they realized and connected that piece, in some cases, one patient, a young 25-year-old white male said, the light bulb just went off in a group one day. And for most of us, it was a moment of clarity. For him, the light bulb had finally gone off.
A focus on ideals. Throughout the treatment, the topics are designed to help inspire the client and to feel motivated. So things like compassion, honesty, taking good care of yourself, respecting your time, all of them are framed as some sort of positive ideal to strive for. Many clients will say that even more than the physical incidents of trauma, it was losing sense of faith in other people or losing a sense that the future could be good. Content that's cognitive, behavioral, interpersonal, and case management. Structure and flexibility. The sessions are structured, there are handouts, there's a check-in, there's a check-out. The idea is to help them know what to expect. And clients will sometimes say it helps them feel contained or safe to know what's going to happen in every session. However, there's also a lot of room for flexibility. The idea is to go as a clinician where you need to go with the client, to let the client decide also where do they need to go within a topic.
We have taken a given topic and we have extended it across 2 or even 3 sessions depending upon the topic.
Simple human language and very strong attention to therapist processes. Countertransference. It's often said that the more intense the clients, the more intense the clinician's response to them. Self-care. In working with very impaired clients, it's very important for the clinician to learn to take care of themselves emotionally, to be able to leave the work when they leave the office.
The process within the clinician is really a central theme, and it was something that we spent a significant amount of time around. Issues of countertransference, issues of just responsivity to the materials from the clinician's perspective, and the process of going through this material. In many cases, we found clinicians responded on a number of levels, both emotionally, personally, certainly professionally and clinically. So an essential piece of a clinician adapting and learning this model is self-care.
And attention to a process often termed secondary traumatization. That the clinician themselves may experience some symptoms of trauma when they're repeatedly exposed to clients' very difficult traumatic histories. And so throughout the treatment, the idea is for the clinician to really focus on themselves as well, and also to use the safe coping skills in their own lives, that the people who best teach it are the ones who are doing it in their lives. It's often said that healing from PTSD and substance use disorder actually requires more than just decreasing symptoms or learning to function, but that at some level it's a transformation of identity, from victim to survivor, from silence to finding one's voice, from powerlessness to a sense of control, from isolation to connection.
My whole past 13 years is just a cloud to me. I don't know who I am. I don't know what I like. I don't know what I don't like. I don't even know my kids. And I've been in treatment and they're with me, and it's like I'm just starting life over. Like I'm just learning about myself. I'm learning about my kids. I'm understanding why I was drinking. I'm understanding my character defects. I'm understanding how to cope with it. It's like I'm starting my life over.
Some examples of the empirical work, the scientific studies on seeking safety. A study by Hien and colleagues published in 2004 on low-income urban women. This was a randomized controlled trial, outpatient, 3 months of treatment. Therapy was run twice a week in individual format, each session being an hour long. And clients were severe in both PTSD and substance use disorder. They had lived with the disorders for many years, typically quite severe and chronic. Seeking safety and relapse prevention were the two manual-based treatments that were used, and then there was a third arm of the study, treatment as usual, where clients would just get whatever treatments they were normally getting. And that was a non-randomized control in the design. And both seeking safety and relapse prevention showed greater reduction than treatment as usual in substance use frequency and severity, PTSD symptoms, and psychiatric symptoms, with the results sustained at 6-month follow-up. Women in Prison, a study by Karen Zlotnick and colleagues published in 2003, 17 women with current PTSD and substance use disorder, primarily substance dependence, the more severe form of substance use disorder. It was a group version of Seeking Safety, conducted an hour and a half twice per week for 3 months. And it was voluntary in the prison setting. Clients could choose to come or not come. They attended an average of 83% of available sessions, high client satisfaction, and 53%, which is 9 of the women, no longer met criteria for PTSD at the end of the 3-month treatment, and 46% no longer met criteria for PTSD at the 3-month follow-up. Substance use could not be assessed while they were in prison because it's a crime, so it couldn't be asked. But at 6 weeks post-release, 70% did not meet criteria for substance use disorder. Criminal justice populations often have extremely high rates of both PTSD and substance abuse.
Trauma and addiction are really big issues for women in prison. A lot of the reasons that they're incarcerated are things like prostitution and things like that, which, you know, there's a lot of trauma involved in that, and getting, God, they tell stories about getting jumped and getting robbed and getting beat up, and so just in the course of the things that they do to support their habit, and the things that eventually land them in prison, have a lot of trauma attached to them, and they don't always identify that as trauma at first. Sometimes they just see it as you know, it goes with the territory. So that's another way that I think Seeking Safety has been great in that environment, is it brings awareness to the women of, oh, so this is why I feel the way I feel, and helps them make sense of some of the things that drive their substance abuse.
Outpatient women, a study published in 1998, group treatment, outpatient, 25 sessions in 3 months. It was run twice a week, each session being an hour and a half. And results are reported on the 17 who completed 6 or more sessions, which was 63% of the 27 women who initially enrolled in the study. There was no control condition because it was a pilot study. Clients improved significantly in alcohol and drug composites on the Addiction Severity Index, one of the most widely used measures of addiction symptoms. They improved in trauma-related symptoms, depression, suicide thoughts and risk, cognitions, knowledge, family and social functioning, and problem solving. They worsened in somatic symptoms, hard to know exactly what that is, but it could just be sometimes somatization is very common in these clients, and when they're no longer using substances, they may be more aware of physical symptoms, or it could be related to early withdrawal from substances. They attended 67% of available sessions and reported high treatment satisfaction. Completers were more impaired than dropouts. This is a finding you sometimes see in studies, that the people who are more severe stayed in. In terms of implementing Seeking Safety, there are several principles that can help to really make it a treatment that can work for clients. First of all, trying to attend in every session if possible to both discussing the skill and rehearsing the skill. It's very natural both for clients and clinicians to discuss a skill. For example, the topic asking for help. Clients can easily talk about that, how maybe they had no one to get help from, how it's hard for them to ask for help, how they don't know how to ask for help, and so on. At some point in the session, the goal is to get them to rehearse it. What would it actually sound like out loud? Can we do a role play? Can you say it in words? In terms of rehearsing the skills, there are a variety of ways to go about it. For the interpersonal topics, it will often take the form of a role play. What does it sound like? I'll play the other person. You play yourself. How might you say it? Cognitive topics may involve a think aloud. For example, the client who's working on the topic compassion. What does it sound like in your mind when you use harsh self-talk? I'm a loser. I don't seem to do anything right. I don't think I'm ever really going to get better. I don't know why other people can and I can't. Okay, now can you try compassionate self-talk? What might that sound like? And have them literally think out loud. There are reasons why life has been hard for me. There are reasons why I'm in the place I'm in, and other people may not have experienced what I've experienced. I think with work, I may be able to make things better in my life. Good. So you get them to do a think aloud and really listen to how they talk to themselves. Behavioral topics, you'll often do a walkthrough. For example, the topic, taking good care of yourself. Maybe the client will commit to making a dentist appointment. And you might want to ask them, do you have the name of a dentist? Do you have insurance or other ways to pay for it? Do you have a way to get there? Do you have childcare if you need it? Are you afraid of the dentist and need someone to go with you? Literally walking them through all the steps they may need to take in order to make that happen. John Dewey, the famous American educator, had a wonderful phrase, learn by doing, that it's by actually trying things out that the client can most deeply learn the skill. Also balancing the client issues with the coping skill. Clients walk into the room with a myriad of issues. They may have had a hard week, they may have had struggles of all kinds, and they're coming in, and at the check-in they'll tell you about what's going on in their lives. You're walking in with a coping skill that may be new to them, and the idea is to connect the two. For example, if your topic is asking for help, and the client said that they used this week, for example, used heroin or cocaine, you might say, did you try reaching out for help before you used or after you used? Did you tell anyone? If your topic was recovery thinking, you might say, what did you say to yourself before you were using? What were the thoughts in your mind before you picked up the cocaine? So the same event, the client has picked up a substance that week, but you may approach it in a different way depending on the topic you're trying to teach them.
Particularly with the HIV positive patients, certainly that group took on a central focus of trauma and substance use disorders, which is intended by the model, but it took a special emphasis around medical case management issues, physical health issues, and really took a central focus on safe behavior to not only ensure the patient was being safe with their own bodies and really taking good care, good self-care, which is a central theme of Seeking Safety, but also in reducing unsafe behavior within the community. So we really took a central focus on how we could utilize the strength of the Seeking Safety model, but within that specific context of those unsafe behaviors of HIV that persons with HIV struggle with on a daily basis.
If there's too much focus on the client issues, it can get all over the map. The session may feel like you're not really making progress and they're just venting or just talking at great length without actually working on a skill. If, on the other hand, you focus too much on the coping skill, it can feel like school, as if you're almost not attending enough to what the client is bringing in the room. And so the idea is to keep moving in and out of the client issues and the coping skill. A key question throughout the treatment: how did you try and cope with that situation? Throughout the treatment, you're trying to help the client learn a fundamental belief, which is, if I try active coping, I can make my life better. No matter what happens, I can cope without using substances or any other unsafe behavior. And so keep helping the client learn to understand what methods did they try, what worked, what didn't work. In terms of adapting the model, there are a whole variety of settings where one might implement it, a whole variety of settings where clients have trauma and addiction. Working with adolescents, working in criminal justice populations, working with HIV-positive clients, working with gays, lesbians, transgendered, and bisexual clients, working with women, and so on. Couple principles if you're going to use the model and you're trying to adapt it for your population. The idea is, first of all, try it as planned. Don't assume on the front end that you need to adapt it or should adapt it before you've tried it out, because the idea is to learn from clients directly, to try it and see what happens. And what you'll find is clients will give a variety of responses, and the modifications, if any, will happen based on how they're reacting. There are two methods, essentially, of collecting information from the client about their feedback about the model. There's an end-of-session questionnaire that they fill out at the end of each session, and they can comment on positive and negative impressions, what they would like to have differently in the model. There's an end-of-treatment questionnaire where they can fill out what topics were most and least helpful to them. What did they like and dislike? What aspects of the format worked or didn't work for them? And at the end of every session, they're going to tell you one thing they got out of the session. So there are multiple ways of hearing their responses to it. The idea throughout is always to use examples from their lives. You know your clients, you know what issues and problems are important to them. And so making sure to use examples that are relevant for them, whether based on ethnic diversity, gender, age, or any other characteristics that make your population unique in their needs. Often what you'll see also in programs is a bottom-up conversion, that clients essentially may influence the adoption of the model, that if clients like the treatment, a broader array of clinicians may come to implement it, and administrators may come to see it as valuable. But the idea, again, is always learn from clients how they're responding to it. In terms of diversity, it's very important to take into account differences in populations, whether based on ethnic differences, racial differences, age differences, gender, and so on.
Well, actually, another part of the traumatic experience for me as a woman and as an African American woman has been just also like in school, people expecting less of you in the sense where, you know, if you're in advanced classes, they making comments like, well, you're here only because, you know, you're an African American or you're a token, so to speak.
Seeking safety has been implemented in a variety of diverse settings. To name just a couple of studies, in the Hien study on low-income urban women, 77% were minority, including 50% African American and 24% Hispanic. In the study by Zlotnick and colleagues in a prison setting, 35% were minority, including 11% African American and 6% Hispanic. And in the original pilot study on the treatment, 12% were minority, all African American in that case.
The prison population is pretty diverse, pretty ethnically diverse. For the most part in our program, we've had primarily white, Hispanic, African American women of all different ages, anywhere from 18 right on up to in their 50s. So, and they all have responded equally positively, I think, to the treatment.
Some frequently asked questions. Do clients have to have a formal diagnosis of PTSD and substance use disorder? Certainly it was developed in research studies and tested when clients had these formal diagnoses. In actual frontline treatment programs, they may not have both disorders. They may have, for example, a history of trauma, but be subthreshold on PTSD. They may have a history of substance abuse, but not have used now for a while, but are struggling with trauma-related symptoms. So it's very common for clients to have one or the other, and to go ahead and focus on the coping skills.
Some of our clients did not have a formal PTSD diagnosis. They, in almost every case, had trauma histories, which we, as part of our intake assessment of all clients in the clinic, measured. So we knew that pretty much all of the clients that had been referred to the groups had trauma histories. However, again, a number of them didn't have the diagnoses.
With all the handouts, how do I select what to focus on? The goal typically is to prioritize any unsafe behavior a client reported at check-in. The check-in is like almost a thermometer, a temperature check. How is this person doing today? And if the client has reported unsafe behavior, the goal is to try and come back to that to the extent you can in the course of working on the topic. Go where the client goes. Have clients scan handouts and ask them questions such as, what strikes you? What would you like to focus on? Really let them take the lead in figuring out what they need to address. Should the client join Seeking Safety only after an initial stabilization period? Because the model was designed for use from the very start of treatment and for all types of treatment settings, for example, inpatient, residential, outpatient, and so on, there really isn't a need to stabilize the client first. In fact, the very goal of Seeking Safety is to help stabilize the client, to help them attain safety. What if a client brings up trauma details during the session? And this will happen. Even a topic that may not seem to trigger can evoke intense feelings or memories for the client. You may be covering the topic, taking good care of yourself, and it may remind them that when they were growing up, they suffered severe neglect by people in the family, or so on. And if they start telling details of it, typically you're going to want to redirect them kindly and supportively. For example, the client may start saying, well, I remember growing up when I started to get beaten when I was about 6, and my father would come into the room. You might say at that point, let me stop you there. What you're saying is extremely important. However, right now, it may not be safe for people in the room to hear what you're talking about. It may trigger other people, and it may not even be safe for you. And so I'm going to ask you, if you don't mind, to tell us about the issue, but talk about it to the extent you can of how it's playing out for you in the present. Now, it's not to say that clients can't ever mention their trauma. In fact, it often is part of the session on PTSD to have clients name the kind of trauma that they experienced. I suffered child abuse. I was raped. I lived through domestic violence for 10 years. I suffered in combat. Whatever the trauma may have been can be named in a short phrase or a sentence, but the idea is to avoid graphic details of it that might trigger them. Also, you can explain that the group needs to stay safe for everyone and that trauma details can be triggering. You may also want to describe readiness for trauma processing, that they may need to focus on goals such as stopping the substance use, stopping self-harm behavior such as cutting and burning, ability to retain some sort of consistent attendance at treatment. Any sort of key goals you have for them can be used as leverage. Once we work on that, then it may be a better time for you to go into the trauma details. How to select clients for the treatment. In general, it's hard to identify characteristics on the front end to define who is going to succeed and who won't succeed at a treatment like this. And so the idea is to be as inclusive as possible. Allow all clients in, and then if a problem occurs, at that point you may need to remove the client from the treatment, or if it's a group, from the group. So typically you'll you might say to the client, you can try out this treatment. You don't have to commit to it. You don't have to say you'll attend X number of sessions. You can try it out for a couple sessions, see how it feels to you. Some clients may be scared of the idea of doing any treatment that has any focus on trauma. And so let them try it out, see how they like it. Also, select clients who want to be in the treatment. It really goes against the nature of trauma treatment to require a client to do PTSD-focused treatment. The idea always in PTSD work is empowerment, letting the client learn to take control, because control was so taken from them by nature of the trauma. And so the idea is, do you want to attend? Try and encourage them, but try not to force them to attend. Are there particular issues for group treatment? You may want to avoid names such as trauma group or PTSD group. Clients may assume that you're going to be discussing traumas in detail. Rather, try and take some name that may feel more optimistic for them. Seeking safety group, or coping skills group. Plan the number of clients based on session length, remembering that the check-in can be up to 5 minutes per client. That is one aspect that you may choose to modify if you have a very large treatment. For example, some people run groups of 30 clients in a session, and you may have to cut down the check-in and conditions like that. However, in general, assume that the check-in will take several minutes per client. So you may want, typically, if you can, 8 to 12 clients in a group. And try and limit the number of clients who may over-dominate or have symptoms of some other disorder that may tend to distract clients, such as a client who's extremely manic and hasn't taken their medications, or any client who has had unsafe behavior that's harmful to the group if they've tried to sell drugs to other people in the group. There may be occasionally times when you'll need to remove them from it if they're doing behaviors that really impair either the staff or the clients from doing the work.
The whole world is open up to me now, you know. I no longer walk into a room full of people and feel inferior. You know, I'm okay with myself. And there's so many things out there that I didn't see before because of this haze of emotions. I mean, I couldn't even identify what it was I was feeling. I just had these emotions driving me. The sky's the limit. Now, absolutely, sky's the limit as far as my life is concerned, and it's the little things in life that mean a lot to me now.
I don't really think about the past anymore. Not to like forget where I came from, but I don't drudge like, oh, I had it so terrible, and if you had my life, you'd drink too. That was my old standby. You drink too. But now I just realize that I can live like a normal person and not have to drink. I can go out and have fun and just like everybody else. And I don't know, it kind of feels good. It's kind of like exciting. It's like every day is kind of like the first day of school. Like kind of nervous but exciting at the same time.
I was just scared, quiet, didn't talk to nobody, didn't say nothing. I didn't think I had an opinion. I didn't have an opinion. I didn't have a choice. And now I'm just like, I'm learning that I do have a voice. I do matter. I have things that I like to do. I can have fun without being drunk. And I can have fun with my children and know who I am. Know that I'm a good person.
Thank you very much for being here today, and I really wish you the best in your continued work with clients. Any questions that anyone has?
When working with clients in a group setting, how do you handle situations when clients become very emotional or get very upset during the session?
That is probably one of the most essential questions, because the nature of both PTSD and substance abuse is that clients often experience very intense emotions very rapidly. And so it's key to learn how to help them learn to contain it, but to do it in a way that's very kind and supportive. For example, a client who's very angry, you might say to them, I really hear that you're very upset right now and very angry, and there's very good reason for you to be upset. Now, you don't have to agree with the client about what they're complaining about or concerned about, but you can just say, you know, I'm sure there's something here that eventually we can work through. But right now, it may not be helpful to try and go into it while you're in this high level of intense emotion. And if you remember, one of the goals of treatment is to help to learn to reduce that kind of intense emotion. And so if it's okay with you, what I'm going to ask you is whether there's a way, whether using grounding or just kind of sitting quietly for a little while, you can kind of come down to a lower level. For example, on a 0 to 10 scale, 10 being the most intense, 0 being not at all, maybe down to 5 or below. And if you want to talk after the session, we can either schedule a time or find a way to be able to address what the issue is. So sometimes what you'll want to do is delay the issue or address it in some very small way now that's not going to get into a combative situation, or typically if clients are very emotional, they're not going to be able to see your point of view at that point.
What are some strategies that you would offer to new clinicians beginning the seeking safety treatment?
That's a really important consideration, because new clinicians often need a lot of support, even if they're very experienced and skilled at doing other models. They may not be used, for example, to working on both PTSD and substance abuse at the same time. They may not be familiar with the case management strategies that can be helpful as part of this treatment, and so on. And so there are a variety of things that can help the person feel supported in that initial learning curve. First, really try and give them some guidance on the front end. Sometimes when people see the book, it's very long, it can look overwhelming. Really help break it down. Typically, I'll suggest to clinicians, just read chapters 1 and 2, which is background about the disorders and the treatment, and then how to run the session. And then pick one topic. For example, a simple one. The shortest one in the book is asking for help. Take that one perhaps. Read it through and just try it out. See how it goes in the session. See how clients respond to it. See what it feels like for you. Second, to the extent that you can provide them with support as they're learning the model, in other words, supervision, whether it's peer supervision or any other kind, other people who have done it, learning from what has worked for other people, what hasn't worked for other people in terms of learning it, can really be helpful, because for example, the clinician who has never run a manual-based treatment before may feel uncomfortable with using a format. Just helping them get some feedback about that, or some reality testing. Yeah, it feels awkward at first. It may not feel comfortable. You may feel like you're cutting the client off, whatever it might be. Finally, make sure that in the beginning, the clinician is collecting end-of-session questionnaire information from the clients. That's a one-page form that's in Chapter 2 of the manual. And at the end of every session, the idea is to hand that to every client, if it's a group, or to the individual, if it's being run in individual treatment. And the client fills it out. And it basically expresses positive and negative responses to the treatment session and what their rating scale is, from 0 to 4, how helpful was the session, the topic, and the therapist, for example. Very quick, but what it does is it gives them repeated feedback about what's working and what isn't.
My question is, could groups be co-led? And if so, what's the best way to use the resources of those two leaders?
Co-leading groups is a wonderful thing to do if the program has the resources to do it. There are many programs where they can't have two leaders in a particular group. And so when I originally developed Seeking Safety, I first tested it in my pilot study using a single leader, because that was typical of a lot of programs. However, Co-leading, many people say, actually feels better for them, feels safer for the clients. It allows one clinician, for example, to make sure they're always tracking the room. The other one might focus, for example, more on working with some of the material or the handouts. But certainly sharing the responsibilities that are so diverse in running any group session with clients who may have so many different needs. And so co-leading is wonderful if it's a possibility, but it certainly can also be done as a singly led model.
Does a clinician need any particular degree or training or any particular area of expertise to conduct this treatment?
At this point, I have never yet seen that there's any particular degree or training that makes someone either very good at doing this model or very poor at doing this model. The characteristics I have seen that matter are things like a real willingness and interest in working with this population, really liking these clients for who they are and what they've struggled with. Also, people who are willing to get cross-trained if their background isn't in substance abuse, to really learn that area of work. If their background isn't PTSD or mental health, to be willing to learn, to read, to go to trainings and so forth. So cross-training is always one of the key topics in working with any dual diagnosis. However, characteristics such as experience level, type of degree, whether it's a PhD or a bachelor's level degree or a master's degree, gender of the clinician, and so forth. Those characteristics actually have not been found related to outcome in general in the psychotherapy and counseling field. So there seem to be some more subtle processes where the clinicians who are good at this work may have some other set of characteristics. And certainly if a clinician does not want to do this kind of work, some clinicians don't like manual-based treatments. They don't want to use handouts. They don't want to follow a format. Maybe those are people who really don't necessarily have to. Certain amount of that can be sometimes worked with in terms of training or having them try it out, but really if after trying it out they feel like this isn't the kind of treatment I want to do, maybe they shouldn't have to do that.
You said to try and be as inclusive as possible when inviting clients to join the treatment. What about patients who may also have dissociative identity disorder and could possibly be actively dissociating during the treatment?
That's an excellent question because in this population, some number of clients will have dissociative identity disorder. And what we typically have found is that some of them can attend the treatment and do just fine, and that the focus on coping skills actually helps reinforce their ability to stay contained, to integrate, to focus on functioning in the present. Typically, you would sort that out with the clinician who is treating them individually. And usually those clients are of such severity, if they do have full-blown dissociative identity disorder, that you would definitely want them in individual treatment. What you'll find is that some clients may respond especially well, for example, to two key things in the treatment. Grounding, that when you see that they're dissociating, just as you would for any other client who's dissociating, what you would want to do is pause what you are doing, take a few moments, and help ground the person, help make sure they're still with you, still present. You might say, you know, you look as though you might be dissociating. Is that going on for you right now? And the client typically will be able to answer that. Yes, I'm kind of zoning out in my mind. I'm not really here. Would you be willing to do some grounding right now for a few moments? And then walk the client through it out loud, having the other clients stay silent but follow along so that they stay grounded as well. And the client typically will be able to come back to the present and stay in the session. Another key process in working with clients who have DID is to focus on containment and integration, not going to look at who the different alters are or have them describe the different alters' experiences, which can be very destabilizing for the client. The goal is to always keep the host personality, that is the main ego, the main person, the one that goes by their regular name, in the room. And so sometimes, for example, a client may say, we had a client like this in one of our groups, at the check-in when she was asked about any substance use or other unsafe behavior, she would say, the big one used. I'm the little one, but the big one used. And we would say, you know, it's really important that you be conscious of your use during the week and take responsibility for that, because it still is you that's using. And we need to work in the treatment with you, with the main person. And so in a gentle way to remind them that the goals are containment and integration, and that the work on exploring alters happens only in individual treatment and only with someone highly trained to treat that disorder.
I'd like to ask if there's any advice you can provide in dealing with termination. As an agency, we've gone through several cycles now of seeking safety and have terminated several groups. And a number of the clients have had difficulty with that process despite our best efforts and in following the recommendations in the text.
In general, your experience is one that I've seen in other programs and have directly seen in client groups that I've worked with, which is that sometimes a time-limited model may feel like it's not enough. The client may feel at the end, even if you do all 25 topics, even if you do it spaced out over quite a long number of months, the client may end up feeling that they don't want to end. And I think it speaks to their connection to you as the clinician, certainly, the program. It's really is a wonderful thing in a way to know that the client got so connected that it's hard for them to leave. However, there is a point where they'll need to leave due to resources, due to moving away, due to the group ending, whatever the cause might be. And so what can be helpful are a couple of strategies. First of all, what you would do in any therapy, which is be clear with the client from the front end what the termination will be so that it's not a surprise to them. If you're going to do 12 sessions, for example, some programs just pick 12 and do that, help them know that from the beginning and remind them of that. If you need to at every session, we're now at session 6 and we have 6 more to go. Just helping the client stay aware of that reality can be useful. In some settings, it can actually help to hear those struggles as feedback, and it may be worth extending the treatment if that's at all feasible. I know that when I've run it as just one topic per session, clients would say, we'd really rather have 2 sessions per topic. If we're doing setting boundaries in relationships, it feels too short to cover that in one session. And so what I've moved to when I've done it, for example, on an outpatient basis, is to allow clients 2 sessions to go into a particular topic. So sometimes you can elongate the treatment. Sometimes helping them to interpret their difficulty in relation to the disorders. Why might it be hard to terminate if you have a history of trauma and PTSD? It could be because relationships for you have been fraught with leavings, with abandonment, with betrayals, or it's been hard to connect with people and feel safe, and so you don't want to leave it when you do experience it. And helping them in general, whenever something difficult comes up in the treatment, if you can help them interpret it in light of the PTSD. For example, if a client isn't doing a commitment and they persist in not doing their commitments between sessions, you might say, many people with PTSD find it hard to follow through on things. They may feel hopeless. They may feel like it's not worth trying in life. That's very common to feel demoralized. So you help them interpret their experience or behavior in a way that hopefully will be validating. Similarly, around the substance abuse. For some clients, it may be that this was a way that they could hook in and work on the substance abuse in a way that felt helpful to them. And so really helping them understand that there are many modalities that work for treatment of substance abuse, and similarly for PTSD as well, that whatever they gained here is great and that they can go out into the world and find other treatments that will be helpful to them as well. And so reframing that the ending really isn't an ending at all. Hopefully it's the beginning of a lot more support and help in other situations.